Good. So this is a September report on where we are, and just a reminder, although I know you all know this as well as we do, osteoporosis is vastly underestimated. It's a really important public health condition that perhaps hasn't had the time and attention that it deserves. People are very surprised when we tell them that 3.5 million people live with the condition. And of course, part of the reason it's called the silent condition is that many of the people who live with it don't know they've got it yet because of underdiagnosis, undertreatment in the NHS, low levels of public awareness. And that's one of the real challenges with osteoporosis, and part of the need to raise awareness and to crack that diagnosis problem in the NHS. Because a lot of people will live with the condition. 1 in 2 women and 1 in 5 men over 50 are expected to break a bone. We know that there are something like 500,000 fractures every year at the moment. It currently costs the NHS £4.5 billion, very significant amount of money, and that will grow because happily we are all in society living longer. That will continue. That's a good thing. But the more we do, the challenge of helping people live better as they grow older will become more pressing for the NHS rather than less. If we do nothing as society, the number of fractures will increase, the time spent living with those fractures will increase, and costs will increase to something like 6 billion for the NHS by 2030. So we are asking government to really honour what was said by the Chief Medical Officer, Chris Whitty, in March last year, and recognise osteoporosis for what it is, which is one of the, as he described it, top 5 public health challenges older in this country. And it's great that Chris Whitty recognised that before the pandemic. We need to not let go of that and challenge government and the health service to do things differently and crack this treatment gap. Because we know otherwise the cost is that there are something like 67,000 hip fractures in England alone, 1 million acute hospital bed days. Wouldn't it be great if we can intervene earlier and get people onto the safe, effective, highly affordable for the NHS medication that can spare people those repeat fractures and give them the support they need to avoid unnecessary repeat fractures and ultimately hip fractures. And there are missed opportunities in doing that. We know that there's low levels of public awareness. 1/4 of people can tell you what the word means, and 3/4 can't tell you what osteoporosis means. And we all, when we're younger, I think most of us, probably me included, have regarded bones as something that, you know, isn't front of mind. And you know, being in this charity has really reminded me how actually there are misconceptions around bones. We know now that they're living, they change, you can invest in them, you can strengthen them, and there's so much you can do, but we need to get that message out to people when they're young, because to an extent, osteoporosis and certainly fractures are preventable. But there is this problem of underdiagnosis. We know that just under 4 in 10 people who get diagnosed prompted their own health assessment, because GP quality of kind of referrals is pretty variable. Who is that 39%? Is it people who are more used to having challenging, brave conversations with GPs, who are used to making things happen? What about the people who are less likely to do that? You know, there are there's lots of evidence that there are people being left behind who should be diagnosed but are not. And the effect of that is that they're not getting the treatment they need. And we published figures, quite startling figures, a couple of weeks ago, which show that 90,000 people every year in this country who need to be on osteoporosis medication are missing out on it, either because they've not been diagnosed or because they have been diagnosed, but they've not had the ongoing support from the NHS, the monitoring, the review, to help them be comfortable with their treatment regime. And we know the treatment regime can be challenging without support. So the treatment gap is 2/3 of women and 43% of men. So startlingly big before COVID. Majorities, perhaps not quite a majority for men, but certainly a majority of women not getting the treatment they need thanks to the gap in treatment. And the results of this is that too many people are having to break bones before they get that treatment. 1/5 of women breaking 3 or more before even getting that crucial diagnosis. Wouldn't it be great if we could intervene and make it so that we stop at 1, as the ROS calls it, or even better, preempt the first fracture and intervene early? 2/3 of people with spinal fractures are undiagnosed. We know that spinal fractures are painful and can be very debilitating in themselves. They're serious by themselves, but they are red flags for further spinal fractures and also hip fractures. Yet 2.2 million people are living with spinal fractures today without knowing it. If we did know it, we could move them onto that effective medication and start working on their bones and strengthening them before they have to endure those repeat fractures. So this is our plan for making a difference. It's got 4 strands to it. The first is prevention. We want to get across that message to people throughout all ages that you can strengthen your bones. To a degree, you can prevent osteoporosis, not entirely, but there are things we can do if only we know about it. The second is care. We know that as a small charity of around 50 staff, we can play a certain role in backing up the NHS and in supporting people directly. But we do know that the NHS is the bigger deliverer that we need to influence and change. And we've got good clinicians, trustees, clinical committee members who have very strong ideas on how to improve services in the NHS, and we want to influence it to change and get better. The third is support. We do feel that we've got a role that we can play directly with people, whether that's through our helpline or increasingly digital advice. We want to have a direct relationship where people can call us, ask us questions, turn to us during those trickier times when the condition may be more difficult to manage, and we'll help them directly. And the fourth is the Cure agenda through our Academy of leading research into new treatment interventions, and Caroline will talk about that in a bit more detail. But here's what that means in practice. 300,000 pieces of advice this year alone, whether that's a really high quality one-to-one helpline call, or whether it's a piece of digital advice or a support group attendance, 300,000 of them. The helpline gets 12,000 calls every year. They're free. That's 3,002 hours of free clinical time with our specialist nurses. Very high satisfaction rating with what the nurses do. And the effect of that is to deal with the excess demand at the moment. The NHS services are still down, as many of you know. Many operating a severely reduced capacity. Our helpline has never been busier, and we're going to make sure we really manage that increased demand. We're proud of our support groups in communities, and there's a picture of the Duchess of Cornwall there opening our academy. We're proud to have put 5.2 million in research grants since 1986.
Oh, there we go. Great. I seem to be in it now.
Hello.
Okay. All right then. Thanks very much. Oh, hang on a minute. Let me just see what I do to go.
So
oh, he's gone.
Get in.
He's gone.
Hello, I think you're joining us. Can you hear me?
Yes. Oh, I'm there.
Hello, it's Craig here.
Hi. Sorry, I had some difficulties getting in.
No problem at all. Thanks for joining us. I'm just talking about the current research investment of the charity, and we put 5.2 million in since the 80s. This year we'll put more into research than ever before, because we know that we need to have thought leadership and figure out ways to manage this condition better. And that leads to the Academy, and the research roadmap, I'm sure Caroline will talk in more detail about this, is about all the interventions we could do in the NHS and society to save costs for the health service and help people maintain strong bones for longer through making better existing treatments, using technology for new treatments, and understanding the causes of osteoporosis better. One of the things the charity's been associated with for a long time is fracture liaison services. Some of you will have an experience of them. They diagnose people better. They have a solid treatment pathway that gets people onto the medication they need and makes sure that they're reviewed regularly to make sure it's working. Now, fracture liaison services started in Scotland. They are a proud British-born success story, but it's a bitter irony that in this country there's such variable access. Some of you will have had some experience, some won't. If you're in England, around half of us have access. If you're in Wales, 2/3. If you're in Scotland and Northern Ireland, in theory, you should have 100% access, but not all of these fracture liaison services are operating to the quality that they need. So there's a real patchwork of quality, and the reason for 90,000 people missing out on the medication they need is because they've either not got an FLS or they have an FLS, but it's not performing as well as it should. And change is more urgent than ever right now. You can see this line chart showing you that the number of fractures identified in the NHS has hovered for some time between about 25 or so percent to just over 40%. Low numbers, the majority of them not being identified. But have a look at the arrow. The first lockdown has cost us a lot of progress. So we were not where we should be before the pandemic. The NHS was missing most fractures beforehand. We've now dropped radically down to around 20%, and we're languishing just below 30. So there's work to do. And we've accelerated progress on the work that we can do through calling an inquiry in Parliament into this very subject. So the question of why is it that so few people have access to a fracture liaison service, just about 60%, and what can we do to make sure that where you do have a fracture liaison service, it gives you the high quality experience that you need. The inquiry's been high profile. We've had 80 responses to our call for evidence. We made a freedom of information request to over 100 trusts and health boards across the country. And the objective of that was to figure out how good provision is in local areas. And we will be lobbying MPs. We will be asking MPs to join with us in writing to trusts and asking them why it is that people can't count on the support of a good FLS in some areas. And we really gave voice to our members in this too. So there's a survey that I hope some of you will have filled in, the survey called Life with Osteoporosis recently. If you did fill it in, I really want to say thank you. It took on average 45 minutes to an hour to fill it in. So it took a while for people. But it's given us the most comprehensive insight we've had for years into what it's like to live with a condition, what effect the pandemic has had, what experience people have got of NHS services, and it's been absolutely invaluable in talking with real credibility in Parliament about what needs to change. And the effect of all of this is that in December we will be releasing a report to the Minister, who we've met with already. We'll be launching it in Parliament. I hope some of our patient advocates can be with us to launch it with us, and we'll be calling for change. It won't be a complaining document. It will be full of solutions. It'll be positive, constructive, but it'll be saying we can't just let happen a majority of fractures being missed anymore. There needs to be change, because otherwise the NHS pays more for the costs of failure, and people are living with avoidable pain. Could have been avoided if it was right, if we did better. And finally, last week we published this, which is our manifesto for change. Like I say, we're pretty small. We have 50 staff. We can make a valuable and meaningful contribution. But if we want to change people's lives in a big wholesale way, we need to influence the NHS as a bigger machine. And these are our 4 calls. We're asking for, first of all, 100% fracture liaison service coverage. Let's make sure that everybody who needs one and who breaks a bone over the age of 50 can count on having a high quality FLS. For every £1 you put in, you get £3 out as well, so it works financially for the NHS. We want to make sure that digital tools, which are already available in some aspects of primary care, so GP surgeries, are integrated everywhere, and they exist. They can help give you a sense, and doctors a sense of what your risk is. And if you happen to be in a surgery that's integrated that system into their IT, then you're more likely to get referred on to the fracture liaison service. Otherwise, quite often you're patched up after the first fracture, sent home, and in too many cases it's having to wait for a second or third fracture that we know is coming before anything's done about it. So primary care is really important. That's the second call. The third call is to join the dots with a new pathway. So we're asking NICE, the regulator, to set out what good looks like and make sure that everybody can count on that good experience from A to Z, because in too many cases it depends on whether you live in the right area and a real postcode lottery. And finally, a fair share of research funding. Osteoporosis and musculoskeletal conditions have really not been invested in terms of research. They account for 8% of all health service spending, £1 billion on hip fractures alone, and it only gets 3% of the research investment. And that's one of the reasons we set up our ROS Academy, to deliver a step change in research. Caroline will talk a bit more about that, but we are asking government to join with us in that. Put a bit more into research, figure out what can be done. Haven't we seen wonders in the last 6 months with vaccine development? What could we do for fracture reduction if we had the right research interventions? I'm going to stop there because I think that's a good introduction to research and the agenda there. But I'd love to answer any questions you've got a bit later, and thank you for all you do as members to enable us to do this work.
That's brilliant. Thank you ever so much for that, Craig. So my name is Liz Parry, and I'm the Legacy Manager for the Royal Osteoporosis Society. And I've got the privilege now of talking to Caroline Sangan, who is our Research Manager. I love talking to Caroline because she's always got so much information to give, so much interesting information. And even as an employee of the Royal Osteoporosis Society, I feel incredibly proud of the research that we undertake here. So hello, Caroline, you all right today?
Hi, can everyone hear me okay? Yeah, okay, great.
Fantastic. So I'm going to ask you a number of questions today. I'm going to put you on the spot today, Caroline, but mainly so we can share all the information of all the exciting research that's going on. So the first question I'm going to ask is, what is the structure of the 3 working groups for the Royal Osteoporosis Society and the Bone Research Academy?
Great. So just before we start this, I just want to say if there's anything that we don't get to cover in the Q&As at the end or anything, I'm always available for anything I mentioned that you'd like to find out any more information about. So I just wanted to preface that at the beginning. So yeah, so building on from what Craig was talking about, when we set up the Academy, it was really the vehicle for how we were going to work towards pursuing a cure. And when we looked at that, we set up an Academy Advisory Committee. Because as with the pandemic and with the development of vaccines, we've got some of the world leading researchers in the UK, and we're very lucky that is the case for osteoporosis. We have some of the world leading experts. So what we set up was an Academy Advisory Committee to look about how we were going to go on that journey for a cure. So together the committee kind of looked at best practice for how other conditions have looked towards pursuing a cure, and development of a research roadmap was the standout option. And doing that via a working group approach had lots and lots of strengths, so that's what we chose to pursue. The topics for the working groups came from looking at a cure and the ways that we could tackle that. So causes came from if we can understand the condition better, what causes it, are there genetic factors, are there things we can learn from rare disorders associated with it. That would help. Understanding that can help you work out how to stop it, prevent it, identify it. The effectiveness came from the fact that we know that we have existing treatments that work, but maybe there's sometimes failures or ways that they're not being implemented as well as they should. So the effectiveness is about how we can implement and improve our existing treatments that we have. We're living in a world where technology is advancing in all areas, and that's definitely the case in research and health. So it was looking at how new technologies such as artificial intelligence, for example, how they could help overcome some of the barriers as well in the treatment of osteoporosis. So they were the topics. So as Craig also mentioned, we've had a long history in research from back in the 80s, so over 30 years. And what we really did was to harness the relationships and the expertise that we've garnered over that time. And that's how we recruited the members to the working groups. So they were the experts in those particular fields. From researchers in 2020, we had about 40 researchers in total spread across the groups from about 22 research institutions in the UK. And also there's lots of representations from Europe as well. We have researchers. Another aspect of the working groups is that with all our research, we always want to put people at the heart of it. So we made sure that for the Academy, we have patient advocates and representatives at all stages, so from the advisory committee down to the working groups. So each working group has a chair and a vice chair and certain terms of reference, so they're all governed in the same way, and we have a very robust way in that all meetings are minuted. In development of the roadmap, there was lots of work into doing evidence reviews, workshops to come up with the lists that you see in that the roadmap, and we're hoping that we're going to have a publication soon coming out that will give a bit more detail about that methodology that we followed. So yeah,
That's fantastic. So much. It's brilliant. Thank you, Caroline. And also, could you please tell us a little bit more about some of the grants the Royal Osteoporosis Society is currently funding?
Yes, so well, we're currently, it's very exciting. We've got a research grant underway at the moment, so we're looking to fund more projects which are aligned to our research roadmap. But we do have a lot of active projects that are ongoing, and we have quite a diverse range. We have ones looking at vitamin D and exercise and the impact that can have. We have some looking at development of a decision-making tool to help with those. Craig mentioned the problems in terms of adherence to medication or the treatment gap. So one of the projects is really exciting, looking at the development of a decision-making tool that would help healthcare professionals to communicate with their patients. And that project's really a collaborative effort with researchers and patients, because you need both perspectives in order to do that. Yeah.
That's brilliant. Thank you very much. And what is the key role of the lay reviewers?
So going back to the fact about we put patients at the heart of everything, that is evidented in the way that we review the proposals that we come in and deciding which grants we fund. So in order to decide which projects that we fund, we have open competition where researchers can submit their applications. They are reviewed by our research grants assessment panel, which is made up of scientific experts, but also lay members. And those lay members play a really crucial role in that process because they give a very unique perspective. So the researchers can look at the science and in whether a project looks feasible, it's been a robust planning, but actually it's the questions about whether the project, does it ask the right questions that would be important to a patient? We strongly encourage in a research when they develop their project plan to make sure that they involve patients and the public throughout that project. So what the lay reviewers look at the plans to see, have they actually done that in the proposal? Have they got a good plan about how they are going to involve patients? What we really like to do as well is, because quite a lot of the research projects are quite technical, so part of the application is for them to put together a summary that will give a very simple, accessible overview of what the project is trying to do. So what our lay reviewers do as well is review that to make sure, can they, is that done well? So as part of our research grants process, the way that we govern that review panel for our grants is we are a member of the Association of Medical Research Charities. It's the national organisation for all the medical research charities, from the really biggest down to the very smallest. But in order to be a member, you have to adhere to lots of certain criteria, and part of that is how you manage your grants round. And the reason you do that is so that we can get the stamp of that we make sure that we have a robust process. That means we support the highest quality research, so we make sure that the money that we receive is put to the best research that we have. And in being a member, we get audited every 5 years. And we were last audited in 2020, and we were actually commended on the inclusion, how we include our lay reviewers, which was lovely to hear as a charity, because we really do, as I said, want to put patients at the heart. So
yeah, that's fantastic. What is the New Scientist Prize, and how does that work?
So one of the other overarching aims of I've covered two of them so far. So the Academy aims to identify what are the research gaps, the priorities, so that we can it can influence how we are going to fund or pursue research, but also how we can use those priorities to influence some of the other bigger funders as well. That's one of the aims. Second is, again, as I've mentioned lots of times, putting patients at the heart. But another aim is that we need to invest in the future research leaders, because the journey to a cure, it might happen soon, it might happen later in the future, but you need to have that succession planning. As I said, we've got research leaders, but we need to be investing in future research leaders. And the New Scientist Prize is an example of how we do that. So we award a £4,000 grant to a researcher at the very early stages of their career. so a PhD student, postdoctoral researcher, and it's for them to do a piece of research into a project, but they give a presentation on what that project is and the results at our conference that we hold, our big osteoporosis conference, held every other year, and it's one of the world leading conferences for osteoporosis, where we bring together all the researchers, clinicians in the field. So for a young researcher, it's a brilliant opportunity to go up there, give a presentation, get the experience, get the name out, their sort of name out there in the field. So, for example, our winner from 2018, Dr. Darling from the University of Surrey, what we do is we get a report back from people who receive it to see what impact it's made. So for her, she was able to pursue her research project. She was able to learn new skills through doing that project. She was able to form collaborations because people contacted her after, seeing her give a presentation. So it added her, it excelled her esteem in the field to be able to do that. So that's one, but we also have other routes. So that's one way that we sort of try to invest in the future. But we also have, from our grants program, we have specific schemes which are targeted. So we have an early career grant scheme, which is targeted at early career researchers. And yes, I think that's it. Yeah, oh no, I missed one thing. We also have for the Academy our Aspiring Leadership Programme that we run with the Faculty of Medical Leadership and Management. And again, that's another avenue that we really are trying to invest in the future research leaders tomorrow.
Phenomenal amount. That's brilliant. Thank you. And what is the difference between project and innovation grants, or innovative grants? Sorry.
Yes. So a project grant. So you'll be able to see it on our website at the moment, because we have an active grant round at the moment. You can find out a bit of more information about the different schemes we have available that people can apply for. So the project grants is our kind of biggest projects that are available. So this year, researchers can apply for a maximum of 100,000 for a 3-year project. So these tend to be quite big projects involving a lot of researchers from different institutions answering some key questions. And this year, those questions have to be aligned to those that are in our research roadmap. The innovative grants for a 10K towards a 12-month project. So a sort of small pilot study. And those are really important because they give a researcher the initial data they can use to maybe apply to a bigger funder. But you can't apply for big grants unless you have some evidence and to sort of substantiate your grant that you're going to submit. So for example, we had a previous grant done by Dr. Richie Abel at Imperial College London, who was looking right down at the nano scale, looking at bone, so really like the tiny bits within your bone, and looking between bones that had a hip fracture and hadn't. And what he was able to use this new imaging technology to show that it looked like the hip fractured bone had less flexible collagen fibers in it. So using that initial data that he was able to get from this pilot study, he was able to apply for another grant, which he got to then to forward that research more. But he would have never been able to get that other grant if he hadn't had that initial pilot study that he'd done, which we'd funded. So yeah, so the pilot studies can be quite because they're things that have not been done before, and they're really sort of cutting edge stuff. So. But yeah, so we'll try and give our breadth from our funding schemes.
Yeah, fantastic. Thank you. And the last question, has there been any research, or is there any planned on why people with osteoporosis stop taking their drugs?
Yeah, so within the Academy, this is an area of real interest for our effectiveness working group. And we actually had a meeting last week because we're doing a key piece of work where it's called a rapid realist review. So often with research, it's really important that it all doesn't happen in silo at different places. Sometimes you need to sort of take that step back and look at everything that's been done previously, and then sort of look at it all together and tell you, okay, what does this tell us? Because it tells you what the next step should be, rather than looking at each thing individually. So they're undertaking a rapid realist review, looking at this exact thing. So we had a meeting last week, and it was talking about, when we talk about adherence, you can look at it in terms of intentional adherence. So it might be that people don't want to take it. It could be non-intentional, so there's limiting factors or physical things or anything that's stopping them doing it. Or it could be non-intentional. In fact, people have questions or they don't have the information they need to make a decision. So it's a really interesting thing. So we're working on that, and what we're hoping to do from all that piece of work is to generate a paper that will set out some recommendations about. So when we're looking at interventions about how we can improve that, based on everything that research studies are telling us to date, what kind of could those be?
Yeah, that's fantastic. See, I told you I love listening to Caroline. I can listen to you all day. It's brilliant. And I do feel very proud to work for the organisation, having spoken to you. But having listened to Caroline today, this is the opportunity now, if you have any questions, if you would like to ask a question either of Caroline or of Craig, then please, you'll see at the top, there's a hand. You can raise a hand, and then I'll unmute you as I go down. So I think I have a question here. Let me just, is it Delith Evans? And I'll just unmute.
Hello.
Hello, Delith. We'd like to ask a question.
Yes, I'm Delith Evans from Carmarthen. On a non-specific or scientific research, has any research been done on how the ROS compares with other countries?
In terms of our research?
In terms of anything really, how good are we compared to other countries, or how bad we are with other countries, or don't we haven't done that research possibly? Craig is going to answer.
Craig, are you able to unmute and answer that one?
Yeah, hi Delith, nice to hear an accent from near where I come from.
Oh, we'll speak Welsh then, shall we?
The answer to the question is that we think in terms of how we're doing as the NHS really, and charities around it, in combating the condition. And the answer to your question is that in European terms, we're somewhere in the middle when it comes to the treatment gap. So the 2/3 of people who don't get treatment in this country, that's not unusual compared to other European countries. Similar for the States, really. You find the prevalence is different in parts of Asia and Africa, for example. But the thing that we take away from that is that the problems we've got in this country in terms of underdiagnosis, undertreatment, low levels of public awareness are not special to us. They're happening abroad. And one of the good things about the Academy is that it's meant to have international collaborations. There are some at the moment. I hope there'll be more in due course, because the vaccine development showed us that this isn't a problem that's going to be solved in one country alone. It's going to be lots of the best minds, world leaders getting together and solving things. Caroline, I don't know whether you want to add something on that from a research perspective.
Yeah, just to sort of follow on that. So on our advisory committee, for example, we have the president and vice president of the International Osteoporosis Foundation on there. So yeah, as I said, we're very fortunate that a lot of the world leadings are nationally based in the UK, but they have those connections worldwide as well. And what we do hope with our research as well. So a couple of weeks ago, there was a conferences. So there was a World Osteoporosis Congress meeting, and there was a special session dedicated to the Academy, the ROS, which is a great opportunity to connect with the whole world in terms of what we're doing as a charity and through the Academy.
And Delith, in terms of how the ROS performs, yes, we do talk to other osteoporosis charities abroad. We do better in some areas, less well in others. We're the biggest, actually, which is, sort of demonstrates how in other countries osteoporosis also goes under the radar. Even the American one only has a few staff, a handful, so we're bigger than them, but they do some impactful work. New Zealand and Australia have very good osteoporosis charities. We're ahead of them in terms of our work in the NHS on service improvement. They look to us as a world leader on that and learn from what we're doing. They're interested in what we're doing in research. I think we're considered quite world leading there as well. We're behind on prevention. So they have launched really impactful bone health brands in New Zealand and Australia to connect with people in their 40s and 50s and talk a bit about bone strengthening. I think if we're honest with ourselves, we're a bit behind where they are, and there are lessons from what they're doing that I hope we can learn soon.
Thank you very much.
Thank you, Dylan. Is there any more questions today? Oh, I think I have another one here. Let me just, sorry, it's Sylvia. I'm sorry, Sylvia, but my computer's just, I'm trying to is anybody able to unmute Sylvia? Because my computer at the moment is, or Sylvia, if you unmute yourself, please.
Hello, I'm Sylvia from the Isle of Wight. Thank you. It's been really interesting so far. It's just a fairly simple question, really. I think, Craig, you quoted a figure of 90,000 people a year who go undiagnosed. Is that correct?
It's subtly different, Sylvia. The figure is the number of people who should be on medication but are not. And it's made up of two groups. The first is people who haven't been diagnosed, but the second is people who have been diagnosed and moved on to the treatment, but they've come off the treatment because there's a lack of follow-up. And that's what Caroline was talking about in terms of treatment adherence and making it easier for people to stay on the medication.
Okay, thank you.
Thank you. Thank you very much. Is there any more questions? There is, if you can't think of one now and after the meeting you think of a question, then oh, I think someone's popped up. Let me just check. Is there another? Christina, if you wouldn't mind unmuting yourself, if that's okay.
Yeah, I've done that.
Brilliant, thank you.
It's just a question pre-lockdown and possibly even about a year before that. We had a meeting in Winchester and I said I'd very much like to assist with the fracture liaison service. I don't have any medical background, but obviously my only background is personal experience. And at the time, they were hoping to set one up in Basingstoke, but as yet, as far as I'm aware, nothing's happened. Is that something that is still on the cards?
Thanks for that question. I'm not sure whether that is on the cards or not, but I will find out for you by talking to the team of people we have at the ROF, which engages with local trusts to try and lobby for FLSs. If it's possible to give a bit more momentum to that, and sometimes it happens because somebody lobbies for it locally, and it can be quite, people can respond, commissioners, MPs and so on can respond to small groups of people being really dogged and demanding an FLS and showing that it works. And we like to give those people as much encouragement as we can. So I think what we'd like to do is to, if you're interested, restart those conversations, and maybe I can take your contact details and put you in touch with our colleagues who can help you strengthen the case.
Okay, thank you.
That's brilliant, thank you. And is there Fiona? Fiona, do you have a question if you'd like to unmute yourself?
Is there an example of a past project, research project, which has followed through to have a impact on patients as opposed to purely scientific research impact at present?
So one example that springs to mind was we had a project, an epidemiological project, which was looking all about fracture rates. And
we've got Caroline next, yeah.
Fracture rates, and one of the things it showed, I think, was that fracture rates were much higher in Scotland at the time. What that project was able to do through producing an academic publication that kind of pulled together all that data was actually able to help inform policy. And it was around the time when we were doing all the FLS work, and it was to show that, and I think around it was the time when we were able to get 100% coverage in Scotland. So it was an example of how that research hadn't been done, the evidence wouldn't have been there to help inform policy at a larger level. And influence change. So that's one of the examples that springs to my head in recent years that has really made a difference.
Thank you. Someone based in Dundee, that's a particularly important one.
Fantastic, thanks for that one. And then is it Carolyn, you have a question, if you wouldn't mind unmuting yourself.
Yes, I've got to have some dental treatment in October, and I've also got osteoporosis, and I was wondering whether that could affect my jaw, the bone structure in my jaw, if I have, because it's some sort of acid. I can't remember the name of the medication, but that would that affect me, because I've also got osteoporosis?
Would you like me to? What I was going to say is that might be a question more for me to pass on to our nurses and to give you a call, because they are incredibly knowledgeable in that area and can give you some very in-depth information about sort of dentist treatment while you have osteoporosis and while you're taking treatment for osteoporosis. And if that would be all right for you, I just think it would be, because there'll be quite a lot of information to pass on, and I can take your details and get. Would that be all right?
Yes, fine.
Thank you, Carolyn. Thank you. And Philippa, I think Philippa, one last question we've got enough time for, if that's okay, if you'd like to unmute yourself.
Thank you. This is really a question for Craig, I think. Caroline has in a most interesting way highlighted the marvellous things the research people are doing. But thank you, Caroline. I'm wondering what sort of proportion of the finances of the ROS go towards research?
Well, that's a really good question. A significant amount at the moment. We're doing more research than we've ever done. The reason for that is that the Academy was a big statement of intent on research, big statement to the world that we wanted to get the best people together and turbocharge the search for new and better treatments. So we wanted to back that up and put our money where our mouth is. We're putting £400,000 into research this year, just into the research grants round. If you add on the overheads and the Academy administration, that's over £500,000 as a proportion of the overall charity spending. Where does that take us? Something between 10 and 20%, I believe. And possibly that understates it, actually, because there's also something like £70,000 of research we've done into life with the condition, into members' preferences of what they want from the charity. So what we've been keen to do is to move from £250,000 every 2 years, and we've moved to a position where we're putting in 2.5 times as much as the charity used to do into research, because we really believe in this.
Thank you.
Thank you. Thank you very much, Craig. And that actually leads really nicely into the reason why I'm here today and to talk to you. Obviously, as Craig's highlighted, there's a huge amount of funding that goes into research, and Gifts in Wills last year represented 60% of the voluntary income that came into the organisation. And if it wasn't for these incredible gifts, a huge amount of that research wouldn't be able to take place. Last year, we saw one of the most challenging years to date with the pandemic. But because of Gifts in Wills, it really was a lifesaver for our organisation. Not only did we survive, but we thrived, and we were there, or we were able to be there for our members and for those people and for doctors to carry on providing information, additional information and extra support for people at a time when they really needed it the most, through our helpline, through our membership, and to professionals as well, to provide them with the additional information that they needed with regards to exercise and etc. while people were isolating at home. So you may not be aware, but this week is actually Remember a Charity Week. You might have seen there's some things in the press where there's an organisation that is also out highlighting the importance of Gifts in Wills and leaving a gift to charity to the general public, but also to solicitors, legal professionals, to try and encourage them just to put a little reminder to people when they're updating or preparing a new will to support any causes that are close to their heart. And here at the Royal Osteoporosis Society, it's also our Legacy Week. And what I do once a year, everyone gets very excited about it, obviously, it's the best week of the year, is that I talk for a whole week about all the fantastic gifts in wills that people leave to our organisation, raising awareness to our staff and to our nurses and to the people answering the phones on the membership and the helpline. Just as a reminder of the importance of the gifts to the organisation, the importance of this valuable income that comes into the organisation to enable us what to do, but also just as a reminder to get our staff to, where appropriate, just remind people that it is just another way to support our charity. Obviously, you can make donations. If you want to, you can run a marathon for us. We've had picnics this year, people having picnics for us. But if none of that is for you, it is just another fantastic way to support the organisation. But did you know, surprisingly, over 60% of adults don't have a will, which even, I mean, that's a current figure. So even through the pandemic, at a time when I think we've all been made particularly aware of we should get our ducks in orders, and, you know, we are all vulnerable and susceptible, but there's still 60% of people that don't have a will. Another interesting thing is, when asked, 35% of people over the age of 40 have said they would be very happy to leave a gift in their will. But the reality is that only 6% of people actually go on to leave a charitable gift, which is quite a shocking figure. But the good news is just by making people aware, just like me today, talking to you, by, you know, for our volunteers, if you were able to suggest it or mention it to somebody that might support our charity, it increases the chance of that person leaving a gift in their will by 50%, which is a staggering amount. It's just being that inspiration and just setting out that reminder. But did you know, some good facts, when you leave a gift in your will to charity, it's actually good for you. This is true. If you leave a gift to charity, on average, not only will you live 7 years longer, but in those 7 years, you will feel happier and more fulfilled. So it's a win-win situation. Giving to charity also introduces your children to the importance of generosity. Sharing the experience of donating to charity with your children, their grandchildren, shows them from a young age that they can help others, sort of, so you can nurture their innate generosity and encourage them to support charities in the years to come. Giving to charity also encourages friends and family to do the same. Leaving a gift in your will can inspire your nearest and dearest to give to causes that are important to you, and also to sort of share the love, as it were. Leaving a gift in your charity can actually save you money as well. You may not know, but the average inheritance tax bill on an estate now is £200,000, and that is set to increase in the future with rising house values and obviously people, you know, years ago saving, and obviously, you know, it can go on to lead to a very large inheritance tax bill. However, if you do choose to support a charity or leave a gift in your will, any gift that passes to charity passes completely free of inheritance tax. So it can be a massive saving to your estate. And also, by leaving 10%, sort of 10% or more to charity, you can actually reduce the percentage of inheritance tax that you pay from 40% to 36%. So it's a win-win situation. Now, it may not be something that you wish or that you're able to do, but as I said, by spreading the word to other people, to the volunteers, to other members about this way of giving, you can raise awareness of the importance of gifts in wills, and you could be the inspiration of gifts in the future. So thank you so much for listening to me and Carolyn and Craig today, and for giving your time, all the time that you give to our charity, and the support, even by being a member or a volunteer, because it really is greatly appreciated. And what I'll do is just hand over to Craig for our last few words.
It's just a real thank you from the team, really. Thanks for being part of this organisation. Everything we've talked about today, whether it's the support services like the helpline, the investment in research, the influencing the NHS, we couldn't do it without our members. Some of you have appeared in Parliament for us, some of you have written to your MP or appeared in the news for us. That really gets the message out there. It feels like we've got a really big job on our hands to give this condition the attention and the airtime in Parliament and the media that it deserves. But we're feeling very energised about making it happen, and thanks for your support in doing it.
Thank you. And I forgot to say, if anybody has any further questions, if you'd like any more information about leaving a gift in a will, or any questions you'd like to ask after this meeting, please do send us an email, give us a phone call. You've got our contact details, and we will get back to you as soon as possible. Thank you very much, everybody, and thank you for coming today.